the area of 312 nanometers to maximize the effect of UVB therapy for the treatment of psoriasis. And interestingly, it needed 11 years until the first publication appeared about the treatment of micosis fungoides. So remember, with fungoides was only 2 years, but with narrowband UVB it lasted for a reason. I cannot understand that after 11 years, until a group from Austria published the first results of the treatment of micosis fungoides with narrowband lamps with excellent results. We could achieve a complete remission of almost all of the early stage patients. Now the question immediately arose, which is better, which to prefer, puber versus UVB, and there's a lot of literature about that, and we picked out one publication from 2003, again by a Dutch group, and I only will focus on this is a retrospective analysis. You remember evidence levels in micosis fungoides and phototherapy are generally low. But the author's conclusion is still valid, and I think it's very important to keep in mind in deciding which to use. What they wrote then in 2003, and again this is still valid statement, is that narrowband UVB for patients with early stage MF is effective. So it is an effective treatment modality. It has, of course, and everybody who does phototherapy in practice knows that it has several advantages over treatment with broadband UVB and puber. And when you treat patients with early stage MF, it might be a good concept and a good idea to start narrowband and have puber in the backhand and narrowband UVB fails to like patients that have high risk of recurrence, and we'll come to that later. Now, the question also arose at the same time, what about narrowband versus broadband? And as I indicated a few slides ago, the question is obsolete. But it's not obsolete because the question is not of interest. It might as well, it might of course be of interest. But it has become obsolete, as demonstrated by a very nice study by Carter and Zug from the United States, because the equipment simply disappeared. I don't know whether you still have broadband UVB lamps in your offices and hospitals. We don't have. And people in the United States also don't have. And what they did is they made a survey among dermatologists and asked them, do you use broadband for your patients? And they simply received the answer of most of the surveyed dermatologists simply was no, because the lamps are simply gone. So the options that we have today is narrowband versus puber and broadband UVB that's disappeared completely. And we simply will never probably answer the question whether broadband might be better, broadband might be better or worse. So with this I come to my first summary on phototherapy in the treatment of micosis fungoides. I already mentioned that almost or more than 40 years after the introduction of phototherapy, puber and narrowband UVB are still first-line treatment options for early MF. And as I already mentioned, narrowband UVB should be preferred in patients with patches and thin plaques. Puber should be reserved for patients with thick plaques, including patients with follicular involvement, which tend to have reverse prognosis. And what is probably more relevant to you in your countries, in America, Latina, than in Europe, it should probably be preferred in patients with high phototype because they tend to respond worse to narrowband UVB, and of course in patients that have insufficient response to UVB. For sezary syndrome, skin-directed therapy alone is of no value, so this is not indicated in patients with sezary syndrome. And for completeness, I show you what we now are discussing in the European Academic Informal Group about the treatments recommendations for sezary syndrome. And this is photopheresis as first-line treatment, Cure-Amplicil and Prednisone as first-line treatment. So I would say this is the rich man's treatment for sezary syndrome, this is the poor man's treatment for sezary syndrome. You can also use low-dose methotrexate. And in the refractory patients, you can use chemotherapy, alemtuzumab, an antibody against CD552. And as already mentioned today, we can also use in a highly selected subgroup of patients, allogeneic stem cell transplantation. Now, so the situation might seem quite clear, but in fact there are more questions than answers if you really go into practice and try to treat the patients. And I will now go with you through a few of these open questions related to phototherapy of early micosis fungoides. And warn you, we have no answer to these questions yet, and I can only give you my personal view on that. And the first question, of course, is safety, long-term safety in particular, but also short-term toxicity of phototherapy, mycosis fungoides, treatment schedules, how to prescribe treatment. Is there a difference between treatment of psoriasis and other skin disease and mycosis fungoides? What is the value of combination treatments? Because very commonly phototherapy is combined with other drugs. What to do when phototherapy fails in mycosis fungoides? And on the other hand, what to do if phototherapy works in mycosis fungoides, because it's the most common situation. And we will go briefly through those questions. Now, toxicity is easy to answer. We know about the toxicity and the long-term safety in psoriasis from the Stern studies, and we have no reason to assume that this is different in mycosis fungoides. So we assume that we have the same amount of long-term and short-term safety with narrow band and with tuber as in other large cohorts with psoriasis that have been investigated for toxicity. So we don't worry too much about that. What about prescriptions or treatment schedule? What do you recommend? How often do you patients? How often should they come into your office? And how about dose escalation? And there is a very practical approach to that. Namely, you do the same as you do in psoriasis because we don't know better. And you're very experienced in treating psoriasis with phototherapy, so you do the same with your patients with mycosis fungoides. And when to stop treatment, my personal recommendation is to stop until when the patient is clinically clear. It's not necessary from my point of view to do pathology at this point. The only reason to do pathology at this point might be if you have any suspicion for any other differential diagnosis coming up. Otherwise, you only need your clinically experienced dermatological vision for deciding whether the patient has responded sufficiently or not. What about combinations? This is a very interesting question. In the assumption, the first line assumption that everybody might have is that combination must be better. So if one drug works and the other thing works and you go back and do, it should work even better. This is the assumption, but of course you cannot make this assumption without the experimental proof. The combination partners most commonly used are the interferons and the retinoids. Generally speaking, we have 3 retinoids, and I think you know these medications. I will not go into detail about that. Regretfully, we have almost no evidence to show whether combinations are better than single agent treatments. And one of the more recent studies about this, about the value of combinations in the treatment of early NF, has been done also by the European Prevention Lymphoma Task Force Group, and was published in the British Journal of Dermatology in 2012. And what Jean Whittaker and his co-workers here did is they compared puba versus puba and bexarotene, so classical combination retinoid puba versus puba alone. And you will be surprised about the result if you haven't seen it before. There is no difference. There is no difference in terms of clinical response. This is a waterfall plot about tumor burden index, and you see that both of these treatments work perfectly, but none of them is better than the other. And of course, the patient with the retinoid puba combination had, of course, more side effects because, as you know, bexarotene is not always correlated perfectly well. And even in terms of duration of response, it turns out that there is no difference. So there's no reason to start with a combination in the patient that had not received treatment already before. Now, what to do when phototherapy fails? Now, that's easy to say. When phototherapy fails, you go to the NCCN guidelines and look up what comes next. And probably you can next year also go to the UTC guidelines and look up what comes next. And there is a number of treatments that most of you are familiar with that, and there's a short list of these treatments that are in general used: retinoids, interferons, low-dose methotrexate, chemotherapy in various mono or chemotherapy or polychemotherapy combinations. We already mentioned photopheresis and bevacizumab. HDAC inhibitors are available in the United States, not in Europe. I don't know either if you have them in America Latina. Do you have HDAC inhibitors? Vorinostat and romidepsin? Yeah, so you have it. I have no experience with that. Yeah. It's also difficult for us to get these drugs, and there's very little experience with that in Europe. And again, for refractory patients, a highly selected subgroup of patients looking at stem cell transplantation can be recommended as a kind of a curative treatment approach. The only single curative treatment approach in mycosis fungoides that we have. Now, what to do when phototherapy works, and I'm already coming to the end of the presentation, which is the most common case. If phototherapy has worked, the question arises automatically, should we stop or should we continue a maintenance protocol? Maintenance defined in this context as the continuation of therapy beyond remission to delay relapse, so to help the patient to stay in remission. We get to is the same with all the other treatment recommendations. The schedules that are practically done by the colleagues in practice are very widely, and it's very difficult to get some sense out of this, what has been published about that. So there is very low evidence about maintenance treatment. From my point of view, it should be considered only for patients with a very high risk of relapse. So the patient with the thick plaques, the patient with the follicular involvement, the patient that has experienced already one or two early relapses after successful phototherapy. That is your candidate for maintenance treatment. And if you ask me which maintenance you should give to this patient, the answer is simple. It should be effective, tolerable, easy to use, and cost efficient. This is the simple answer. The complicated answer is there's a long list of those treatments, and I don't know which one to prefer about the other. And for this reason, I have arranged to be in a more, as you might say, geometrical order, because I have no other order to recommend. But all of these treatments might fulfill the criteria here, and you can, of course, on an individual basis, recommend this to your patient. And with this, I come to the second summary of my presentation. This is almost the last slide. And this is also a historical text. It was written in 1994 by Paul Bunn, one of the oncologists who set up early principles in the treatment of the disease. And I modified it almost I made almost no modification to this text. So it's almost completely the original version of 1994. And it reads, patients with early nephril relapse after one topical treatment should be retreated or given another when the relapse is confined to the skin or asymptomatic nodal sites. So you can retreat the patient, you can rotate your patient through topical treatments. Systemic treatment is also important. It should be considered for patients with symptomatic visceral or nodal disease, including patients with sezary syndrome, who should be treated from the outside with systemic treatment. And for cutaneous disease that is refractory to one or more topical approaches. Whenever possible, patients should be enrolled in therapeutic trials. Multi-center study groups have been set up, so there are multi-center study groups with the aim to organize such trials, and have shown you one example of such a trial. And the most important international study groups that deal with this disease are shown here: the Cutaneous Lymphoma Task Force and the International Society for Cutaneous Lymphoma. And with this, I thank you for your attention.